Hi, everyone, and welcome to the Muslim Sex Podcast. Thank you so much for tuning in. I really appreciate your patronage, and I would love it if you could leave me a 5-star review because that really helps me. And if you could like and share this episode with somebody that you know that may benefit, your friend, your colleague, anyone, I'd really love you to share this podcast, especially if you find value in the Muslim Sex Podcast. Also, I'd love for you to subscribe to my YouTube channel and follow me on all my social media. Also, as you probably know, if you've been listening to this podcast, is that I have a practice that is now open in Chappaqua, New York. I see patients for menopause and sexual health, as well as regular gynecology. So if you are looking for a gynecologist that actually spends time with you, that has time to listen to you, then I would invite you to come and see me in my practice, and I'd be more than happy to take care of you. So make sure if you live in the New York area, or even if you don't, come and see me in my office. I'd love to meet you. And also, last but not least, is that I am hosting again my retreat in Morocco for 2025. So if you are looking for a gift for a family member, a friend, yourself, make sure you take a look at our retreat, the Love and Nourish retreat. It will be held September 19th through the 26th, 2025. Again, this year in Morocco, we will be visiting the same towns. We will be in Marrakesh and Essaouira. And as always, we will be providing information and lectures on menopause, perimenopause, nutrition, and also going for cooking classes as well as excursions. So don't miss out. I know a lot of people were sad when they missed out this past year on the Morocco retreat. So make sure that you go and visit the Love and Nourish retreat hosted by Caria Retreats. And now onto the episode. I'm an American board certified ObGyn, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about midlife women's health. But before we get into it, a few things I want to make very clear. This is not any type of medical advice. If you have any questions about your health, definitely feel free to reach out to your healthcare provider. If you have any questions about your religion, make sure you speak with your friendly neighborhood religious leader. This is the Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So I am super excited to have on with me today Dr. Tina Sogocio. Dr. Tina, if you could please introduce yourself to the people listening and watching.
Yes. Hi. Hello. Thank you for having me. I'm Dr. Tina Sogocio. I am residing here in California, Merced, California. It's in the Central Valley. And I am an ObGyn, and I have been in practice since 2009. And yeah, I have been more focused in the last 5 years on midlife women's health, as I have also transitioned into that stage myself, and really enjoying the second part of my career doing a lot more focused care.
Isn't that how it always happens, right? When we're in our reproductive years, we're doing all the deliveries, the babies and all the stuff. And then as we ourselves start to age and start to go through midlife, it's almost like a natural transition for us, right? To start focusing on midlife health and menopause and premenopause and all that stuff, just because it's what we are going through. And it's almost like we want to know more, not only just for ourselves, but also for our patients.
Yeah, I couldn't agree with you more. The trend, as women who can certainly empathize and with our patients much easier because we can go through all these different stages, along with them. I think it does lend itself to giving us a little bit of an edge, with our patients, in having that shared experience. And so, you and I both are in the midlife women's health space and perimenopause, menopause space. And we so desperately need our ObGYNs to rise up to the need of better care for them. And I found myself, needing to take care of myself. And if I could take care of myself properly, I could probably be a much more effective and impactful provider for my patient population that I was also aging with. So, yeah. So here we
Yeah,
are.
absolutely. Absolutely. I agree with you 100%. I think that, my interest peaked in perimenopause, menopause, because I myself was going through it. And still going through it. I think,
Yeah,
I think that
ongoing.
yeah. Yeah, so I think that really is what the motivation was. And then trying to figure out about sexual health, I think that had a lot to do with not really growing up with much education surrounding that. And I never went to sex ed. My parents didn't let me go. They weren't really sure what was going to be taught, so I never did.
Yeah.
And so I think that, not growing up with any type of information and then not really seeing any female mentors. I mean, I think that there was a lot of reasons why I decided to go into women's health. So tell me, let's talk a little bit about you. So why did you go into women's health, and what made you now, you're GYN only. I know you did obstetrics for a while. So tell me a little bit about your story. What happened?
Yeah, when I was in medical school, I really did not have any inkling about obstetrics gynecology. It wasn't a field I was very knowledgeable about. And so even when I went through medical school, my eyes weren't my interest wasn't in this field. But after my third year of doing the different rotations at the time, OBGYN was my last rotation of my third year, and uh, it really grabbed me. I did not I was It was a very unexpected, transition to be completely, enamored with the field, and I think part of that draw was it was a little bit of everything, and for someone who has always felt my calling was to be a champion for women, it just made for the perfect fit. A little bit of surgery, a little bit of, general practice, family medicine, certainly the specialty care that, GYN education afforded us. Um, and so it just felt like the right fit. And then most of my fourth year in medical school was centered around doing as many electives around women's health and OBGYN. So uh, after that, it really wasn't, I had no regrets. I really dove into my residency, very intently. Interestingly enough, I was almost 33 years old when I started residency. And so for me, it was a little bit of a challenge being a little older. I had gotten married prior to starting residency, and then 2 years in, I had our first child, and then by the time I graduated from residency, we had our second child, and so my challenges were very different. Going through residency, being a little older, uh, and having two young kids. And then when we moved out to California and I started my private practice in 2009, yeah, it's just been a fast paced 18 years of doing this. And so I've just gravitated to this field more and more as I've gone through the years. And I think it's because I just feel we need to push our women to just rise above kind of all the misinformation, all the lack of good care, at all stages. And certainly as a woman, I wanted to make sure that I could take care of myself in the process, but also I have a daughter now who this all makes much more difference to me and matters to me more because I want to pave the way for her as well so that her care doesn't have the same challenges that maybe you and I have had. And
Yeah.
so,
Yeah. Yeah, I mean, I think I hear a lot of advocacy in your story and, empowerment. And that's really my focus as well. I really went into OB because I didn't see a lot of women that look like me in the field. I didn't see a lot of women talking about things that, were considered taboo at the time and, still are. I mean, I think there's a lot of shame and sex negativity and things like that. And I think that for me it's been really just sharing knowledge so that women globally can feel empowered, and so that they have sexual agency and they can feel like they, perhaps if they listen to this podcast, then they can gain some insight into like midlife, but also sexual health and intimacy coaching and mindset and all of this, which I think is so important. And I think that a lot of women may not know and may not understand their own bodies. So I think it's really important. And so I really resonate with what you're talking about with the advocacy and the empowerment. And it's great that you have a daughter that you can also help empower and show her what the way that things are, and really give her vocabulary for
Oh,
things
absolutely.
that
Yeah.
causing any type of dysfunction. I mean, I don't have girls, I have boys, but, I seek to help to teach them so that they can also be advocates for their future partners or, whatever, or just even for their own knowledge, right? I mean, I think that's really important.
Yeah, and I think what the last 18 years have taught me also in being in practice is, and when you're listening to your these patients, every day, I was just soaking in how much they didn't know about their bodies and about anatomy and about, being familiar with their own body parts. And it always struck me as, what are we not doing enough of to have women be comfortable with their own anatomy, to be able to advocate for themselves in a doctor's visit, or a healthcare visit. And through the years, I've really felt like, wow, it really struck me that a lot of women just didn't know, and not to no fault of their own, but, you know, it just made me feel like I really needed to spend more time giving them tools about understanding their body and giving them the proper names of their anatomy and showing them pictures. And now that we have so many more tools at our fingertips, like social media and everything that's, online and available, but in the early years of my practice, didn't really have a lot of that.
Yeah.
So it's always just fascinated me that women just, in my early years of practice at least, the women just didn't have a good knowledge of their own bodies. And I felt like, gosh, if we could just educate there, start there,
Yeah.
women might be able to advocate for themselves better in their, healthcare visits, because they know their bodies. And so
Mhm.
that's kind of been an interesting turning point for me in my career, is like really spend the time educating women.
Yeah, I think that education is really, really important. And, to your point, I think that sex education, a lot of times in a lot of, I did a whole presentation on this a few years back, and it really depends on your zip code as to what you learn in sex education, and who runs the board of education for your schools. And
Interesting.
that's really going to guide what your children are learning in sex ed. So, for example, like in Texas, they really emphasize abstinence, but they have the highest rates of teen pregnancy. So that was, I thought that was really interesting fact. And I don't know if it's changed now, but if the I did my lecture about 3 years ago. And so at that time, that was the statistic. I don't know what it is right now. But, I think that, we focus a lot in sex education going through what different states teach, kids. It's a lot on pregnancy prevention. It's a lot on sexually transmitted infections. It's a lot on abstinence, but nobody focuses on consent. Nobody focuses on pleasure. Nobody focuses on really making sure that boys and like women and men, right, that they also, or at that time boys and girls, that they really know their anatomy, that they understand what it is, and that they even just have the vocabulary for it, right? Because
Right.
a lot of times you come in and women are calling the vulva the vagina,
Yeah.
and they don't really know that that's a separate part of their anatomy. They don't know what gives them pleasure, what doesn't. So I think that a lot of it goes back to, not only just our environments, our culture.
An interesting point, Sadaf, because, I have an interesting background. I am from Filipino parents, so very, very Roman Catholic. I was born in the States, in Ohio, and I grew up there, and I was in all Catholic schools, and my high school was an all girls Catholic school.
Wow. So what did you learn?
I mean, I'm trying to think back specifically, but your comment about zip code, I'm in the heartland of Ohio growing up in an
I know.
all-girls Catholic school. So, I wonder, it makes me wonder how much of that is true. And I almost felt a little naive, much more naive than I realized when I went off to college in St. Louis in the Midwest, even, furthering that Midwest development and so I I'm thinking, I'm pondering about that comment because I think a lot of it is true.
Yeah.
So yeah, very interesting.
It has, yeah, absolutely. It has a lot to do with, where you're raised and where you go to school and
Mm,
who controls that board of ed. That's going to
yeah,
guide really what you're learning in school. So
yeah.
absolutely. So I'd love to know is in terms of, midlife women's health, what is it that most women come to you for? Is it, like, for example, a lot of women come to me now for like perimenopause, right? For the hot flashes, the night sweats, and they're just not feeling like themselves anymore. They're having a lot of joint pain, all of those things. Or I get women that come in for decreased libido, but it's not separate, right? A lot of it comes together. So they may be feeling awful during this perimenopausal transition, but then also because that they're not feeling good, even if they had a normal libido before, their libido may be like in the tank
Right.
because they just don't feel well. They're exhausted. They're not sleeping. They're, in that sandwich generation where they're taking care of their parents and also their kids. And so they just don't have any time left to themselves or to their relationship, to their partners. So
Yeah.
what do you see mainly in your office?
Yeah, I would say it's very much the same. I mean, it's really a widespread of women in the ages of late 30s to even 70-year-olds that I'm seeing, 60, 70-year-olds that are coming in. I know I'm one of the few providers in my area that really concentrates on midlife women's health. Uh, but my what I've seen especially in the last year is just a wider range of that midlife age group. I feel like, the 30-40 year olds are really, being proactive and coming in, at the onset of, some new symptoms. But I also feel like the 65 plus year old women are coming back and are like, we're reclaiming our health. I mean, we've been neglected for the last 20 plus years.
Yeah.
And so it is all of what you just said and everything else. They want everything, they want to know about everything from A to Z. They are much more open about the sexual health conversations, their bladder health. And a lot of metabolic weight gain and the shifts in their metabolism. So yes, the typical vasomotor symptoms, the joint pain, the insomnia, and all of that. But I find that the patients seeking my care are a lot more specific. They want to know about everything, and they want to address all the issues now. And so that's what I'm finding, which is fantastic. Because before, women couldn't even bring up their urinary incontinence without feeling belittled to some degree, right? Oh, you're
Yeah.
just older, Mrs. Jones. Don't worry about it. That's just the way it is for you. And
Right.
that's so sad. That
I think you're right. I think that since social media, and I think that since people are becoming louder on social media regarding gender urinary syndrome of menopause during and about the symptoms of menopause, and we have a lot of these influencers that talk so much about menopause, perimenopause, and now it's on Oprah and it's on
yeah,
the New
yeah,
York Times and all of that. I think that women are absolutely feeling like, oh my God, this is what I've been going through. And, I can't believe that I've been dismissed for so long. And I really need to find a practitioner that's actually going to listen to me because, I've just been suffering this whole time. And to your point, I have also seen some older women, women in their 60s, 70s that are coming in
yes.
really upset that they missed their the benefit of hormones and, those that are coming in with osteoporosis, those women that are coming in with, hyperlipidemia, like a very high cholesterol, and, upset that they just weren't given that conversation, weren't given that opportunity to really decide whether or not they wanted to take hormones. And now are feeling like, you know what, I kind of want those. I don't know if it's still for me or not. So, what do you tell your women that are older that are looking into all of this?
I try to validate every woman's, experience, especially for the ones that you and I both know in the last 20 plus years, we neglected a lot. And,
Yeah.
you know, rightfully so, they're coming in and demanding a little bit more information. Is it too late for them? And I tell them no one, it's never too late for it, improvement at any age. I always try to make sure that I give, as much education as I can, certainly update whatever information, they have had at this point. And also just update on, treatment modalities and, the retracted information about hormone replacement therapy and vaginal hormones. Uh, but certainly giving them some hope that how many ever years they have left, they're in charge. They have a right to feel better at any age and to have an improved quality of life at any age. And anything can be improved if they want that, but also to make sure the expectations, that we're very realistic about what we can improve at this point. But I am very much about, if this is what, you want, Mrs. Jones, I'm happy to have this conversation and see what's possible. I don't think that I'm not one to close the door on anybody, you know.
Yeah,
So
yeah. I think that's really great. I think I have that same conversation, and I have them do, I check what their ASCVD risk is, right? Their risk of like a heart disease and stroke, and look at, are they smoking? What is their cholesterol? What do they have, high blood pressure? All of that, right? I look at that, those risk factors. I also look at, I have them do, if they are older than that, that timing hypothesis in menopause that we know that, that they talk about, of less than the age of 60, or within 10 years of menopause. I have them do like a calcium score as well to see whether or not there's plaque buildup in their arteries, to see whether or not they would be a candidate for menopausal hormonal therapy. And then go from there. I think, it's shared decision making, and we really have to kind of meet the patient where they are. And like you said, really validate their concerns, and affirm that, they've been struggling as well. And only recently have people gotten really loud, and see whether or not they are candidates, right?
yeah, absolutely. I also think in regards to intimacy health and sexual health, I mean, there's this somewhat age bias that, women and possibly men are not having sex after a certain age, or they're not, that, we just kind of write them off after a certain time. But I have had plenty of 65-year-old and older patients who are coming in and say, listen, I just want to have comfortable intercourse. I don't want to be in pain, and things have changed. And I I love the fact that they're still as active as they are. And so I think even just that alone, I want to make sure that age isn't, for me, age isn't a factor. Like, if you want to have good sex, if you want to have comfortable intercourse, if you want to have better bladder health, whatever that looks like, you know, I'm here for you. Absolutely. And it gives me hope too. I'm only 55, and I want I want to know that I can secure that kind of future for all parts of my health. And so you know, those older women coming in, yeah, I'm excited for them if they're embracing all of that.
Yeah, I agree. I think that for a long time, I would see patients in the clinic that would say that, I'd ask them if they were sexually active, and they'd say like, no, no, I gave that up, a long time ago, as if they were like giving up smoking or something, and I was like, well, you don't really need to unless you want to, like
Right.
if it was something that you never really cared for, and you're just so happy that you're not sexually active anymore, that's totally your decision. But if it's something that mattered to you,
Yeah.
and something that was an important part of your relationship, or a relationship with yourself, then, how can we improve that? And what
Yes.
is it, that I can do to support you in
Right.
that, so that you continue to be as sexually active as you want to be, right? I mean, not everyone, that's not important to everyone, but to some people it is really important. So I think that it's, it's helpful. And I'm glad, you're having those conversations. I think a lot of people are having those conversations. And I'm so glad that women, right, that come and see us are more open to having those, because again, there is a lot of shame. There's a lot of stigma surrounding. And if you add the cultural component to it, I think it's funny that in the US, right, like you see like people having sex all over the place in the movies and the media, in, like magazines, and they're always talking about how to have the best sex of your life. But then when you actually talk to somebody about, they become very like, I don't want to say prudish, but they become like so inhibited because they just, right, they don't have those conversations. But it's kind of like a double standard. Like you see it everywhere, but they're afraid to have those conversations, whether it's with their partner or whether it is with their doctor, because they're just afraid of, what, maybe what that other person is going to think of them, or, maybe they're going to think they're too old, or maybe they're just going to, wonder whatever. They have a lot of like preconceived notions. What, do you ever
Absolutely.
see that?
Yeah, I totally agree. I think, what is much more apparent and readily apparent now with all the social media outlets, there's a little bit of this glorified idea of intimacy and sexual health. And yet, behind closed doors, it's a much different picture for many, many people, and especially women. And yes, there's a lot of preconceived notions. I'm sure you've had patients that, yeah, it hurts, but I just don't want to upset my husband. We got to break that kind of barrier down for our patient to say,
Right.
it's important for you to have comfortable intercourse just as much as it is for your spouse. So I think like all those kinds of preconceived notions, I think are so important to really kind of work through.
Yeah.
And I also think that there's there when they get that that later stage of life, especially for women who have lost their spouses or their partners and are widowed, and they're seeking out another relationship. I want to give them the tools that will not make them afraid of re-exploring that level of intimacy again, because connection is everything. No one wants to die alone or go through the rest of their years alone if they don't want to. And so I think all of these things are so important to address with, women in that age group. Just give them hope. I mean, that's the least we can do as a provider, is give
Right.
them hope and then hopefully treat them appropriately. Give them the tools. Give them the medication. It
Right.
is not, you and I both know this. It is nothing off our plates to give them vaginal estrogen. Nothing, right? Like,
Right.
take your
Right.
tube and run with it. If I don't ever see you again, you go ahead and take that vaginal estrogen with you wherever you go. So,
Right, right. No, absolutely. And, I think to your point, when you talk about intimacy, right, there's so many different forms of it. That you have, the physical intimacy, there's emotional intimacy, there's experiential intimacy, there's intellectual intimacy. And so I think it's really important for us to, help our patients find that with their partners, and, give them the tools, like you said, to find that closeness, and allow them to be vulnerable with their partners, so that they can have a more fulfilling life if that's what they really want, right? And I think that that's super important. So tell me now, if when it comes to sexual health, what are the things that you often see in your practice?
in terms of like
Do
what
women, yeah, do women come to you for like sexual pain? Do they come to you for a decreased libido? How about decreased orgasm? Like when you see women, so in midlife, we know that in midlife, that's typically when we will start to see sexual dysfunction, usually between like 48, the ages of 48 and 65. There was a study that was done, the Preside study, that noted that the most common reason women come to a provider, or the sexual dysfunction that shows up in midlife, is decreased libido.
yeah.
And about, I believe it was like 12% of women actually present with distress due to their decreased libido. And then after that, it's orgasm and then arousal. So, I'm just curious to know in your practice if you
Yeah.
notice that as well, if it's decreased libido or is it pain with sex or is it,
Yeah.
inability to orgasm?
I think the majority of patients, when in the course of the conversation about symptoms, decreased libido is, you know, probably top 10. But I try to really pinpoint decreased libido because, like you said,
A
it
huge topic.
it is a huge umbrella, and I remind patients, that it is a large umbrella. It means different things to different people. But and then I try to get more specific. Is it, physical pain upon penetration? Is it friction pain because you feel dry? Is it the inability is your sensation decreased? Like, do you feel lax or open? That's a common
Yeah.
comment that I hear. Inability to orgasm, longer to orgasm, no orgasm, the anxiety of having pain because they experienced pain before. Uh, and then certainly there's, a small subset of patients I have to, what comes out through the conversation of trauma, of any kind of abuse or any kind of, sexual trauma in the past and how that, kind of layers into their decreased libido. And so it for us as providers, I think we be respectful as much as we can pick up on, from our patients, but it really is about opening up all of those different parts of that conversation, because decreased libido, is just not so much the desire, or, when my husband taps me on the shoulder, I don't want to have sex, kind of thing, like needing to explore some of those things, for patients. So I do think that it just takes time to really get much more specific with them, and then to take each one of those things and go a little bit further if they're willing.
Yeah. Yeah,
And I
absolutely.
Yeah, and I don't think it's solvable, right? Like, it's not solvable in one visit sometimes, because sometimes the patients don't even realize what's really wrong. So decreased libido is often one of those things I say, let's talk about it and what really is going on for you. And then let's figure out step by step how we can improve certain things. And even sometimes libido is in the backdrop of just poor body confidence or decreased body confidence because the midlife woman has gained 20, 30 pounds and she no longer feels comfortable in her own body. So decreased libido can just be, the the mirror, so to speak, for some of those other things. So
100%. Yeah. I mean, when patients come to me for decreased libido, I look at it through the lens of the biopsychosocial model, right? So I
Mhm.
want to know, like, biologically what's going on. Is it, neurotransmitters in the brain? Is it that you're having pain with sex? Is it that you're not able to orgasm? Is it, you have like some issue in the spine? Is it, do you have depression? Do you have new onset anxiety? Do you have, did you grow up with sex negativity? What type of attitudes do you feel about sex? Were you ever interested in sex? Were you not interested in sex, right? Is it that maybe they feel like they have decreased libido because they feel like their partner has a high libido? Like, what is that decreased
yes,
libido in comparison to, right? Maybe their partner is really hypersexual. I don't want to say hypersexual, but, they really have a very strong libido and maybe they don't. So, when you look at it through the lens of biopsychosocial, I agree with you. I think that there's such a huge component. And, I think it's really important to address all of those things. And then when you look at the solutions, right? Like everyone just wants a pill, but we do have some pills, but oftentimes, it has to do with the relationship. What does the relationship look like, right? Are they talking outside of the bedroom? Because if they're not talking outside the bedroom, they're not talking inside the bedroom. They're not talking about what they like, what they don't like. Are they talking about desires? Are they talking about fantasies? Are they talking about other things that might increase their libido? Are they able to connect on different levels? Are they emotionally connected? Like, there's so many things, and I agree with you. It's not something that can be solved in in one visit. Typically, those require multiple visits. And that's why it's good to have this concierge model that you and I practice, because, you really need a long time with the patient. It's not something that you can talk about and discuss in one visit or even in like 10 minutes, right? This is something that requires a long conversation.
And that is a huge disservice to our patients if we think
Yeah,
we can accomplish that in 10 minutes or much less one visit. And, it's so important to, it's such an exploratory conversation, because sometimes it's just even as much as like, you know, patients realizing in the course of that conversation, they're like, "Oh, well, I guess I never really had a strong libido to begin with." And then, what is a libido? What's one libido? One patient's libido is different than for the other patient, and how it's defined for them. Is it just an
sure.
orgasm, or is it just how you respond to your partner upon touch? Or yeah, so it's so much more than that. And I think, if we're really truly caring about the sexual and intimacy health of our patients, we have those difficult conversations. And if our patients are not ready to have them, fine, we wait and we just, respect, where they are. But it has to be part of the overall conversation. It's not just, that, yeah, I have a dry vagina. What else is going on? Like, we got to talk about that. Yeah.
Right. Absolutely. Absolutely. So, what would you say would be the three most important pearls for somebody listening to this podcast? And, if they were to walk away and what would you say would be the three most important things that you always tell your patients? And, something that you'd want to tell the listeners or the viewers?
Yes. Oh, great question. I don't know if I have three, but I'll give three. But we are blessed with a lot of resources now, more than what you and I even had when we were in our training. So I always urge women, find as many resources as possible. Books, podcasts, social media accounts, newsletters, get on people's newsletters, try to just gather and listen and read as much as you can. And I think that leads into my second one, Pearl, is that because it gives you tools to have discussions with your healthcare provider, or unfortunately for many women, they have to go through a couple providers. But that makes it, I think, easier for women to, stand firm in what they're really looking for, what their expectations are with their visits, and also to just stay hopeful that there is a provider out there for her that she will connect with. It is unfortunate that it takes, on average, what was that, 5 to 7 visits before a woman will get treated or at least listened to. But stay the course, because there will be a provider. And even now we have the online providers, that online, companies and practices that are available. And I think it's be your own advocate as much as you can, because nobody else will do it for you. And as providers, we can provide all the tools and the resources and education. But at the end of the day, the patient really has to be her strongest advocate. And I hope that that women continue to, you know, inform themselves of how they can be their own advocates. And so, yeah, those are the three main things.
That is awesome. So, for somebody that's listening to this podcast, that's watching you on YouTube, is thinking like, wow, she is fantastic. I would love to be her patient. How can patients find you? How can they get in touch with you? How can they make their first appointment with you?
Well, I appreciate that stuff. I am in the state of California. My medical license is in California. I have a very strong telehealth practice in the state of California. I am just about to launch some midlife menopause coaching that I can do hopefully nationwide. But I do have my own Instagram account, and I have a private practice here in Merced, California. And I can leave all that information with you and repost it. So, yeah.
Okay, fantastic. Well, that would be great. And well, it has been fantastic having you on. And well, we are done here, and it's been real and really intimate. And of course, it's not meant to be any type of medical information. So if you have any questions about your health, please speak with your healthcare provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.